Welcome to the deep dive. Today we're getting into something really specific, an intensely focused procedure in gastroenterology, managing esophageal strictures.
Right.
We're talking about that narrowing of the esophagus, the tube that connects your throat to your stomach.
And it's a field where precision is, it's everything. Our mission today is to really get into a very specific, and I'd say high stakes protocol,
Which is?
performing what's called Bougie dilation, using these specialized tools to stretch the esophagus, but doing it without a guide wire.
Yeah.
We really have to define the absolute boundaries here. When is this technique safe and effective? And when is it just plain dangerous?
And to even start that conversation, we have to talk about the tools themselves. They have their own language of scale, this French sizing system.
Exactly. And it sounds abstract, but it's completely tied to safety. You have these dilators, and they range from, say, 20 up to 60 French.
Okay, so what does that mean in real terms?
Well, the key thing to remember is that 3 French is roughly 1 millimeter. So a 60 French dilator, that's creating about a 20 millimeter opening.
Which is pretty significant.
It is, but the real magic isn't the final size, it's the sequence. The whole idea is moving up in very small increments, maybe 2 to 4 French at a time.
So you're not just forcing it open.
Never. You're going from, say, a 50 to a 52, then a 54. It's that slow, sequential stretching that allows the tissue to expand without, tearing.
Okay, let's just dive right into the biggest question, because the decision to not use a guide wire, that feels like the main safety checkpoint.
It is. It's the first and most important rule.
So when is it actually permissible?
The rules here are, they're not flexible. Guide wireless Bougie dilation is reserved only for what we call simple strictures.
Simple strictures. And is there a number attached to that?
There is. The source material gives us a pretty clear rule of thumb. The narrowest part of the stricture needs to be at least 10 millimeters wide already.
So we're talking about an esophagus that's narrowed, for sure, but still has a decent opening. What does a simple stricture actually look like to an endoscopist?
They're looking for short, non-complex blockages. Think of something like a thin membrane, like a web of tissue.
Okay.
Or the classic example is a Schatzki's ring, if you've ever heard that term. It's this thin, circular shelf of tissue that forms right where the esophagus meets the stomach.
And because those are symmetrical and short.
Exactly. The Bougie tip can find the middle pretty easily without a guide.
But I want to push back on that 10 millimeter number. Is it really just the number, or is it more about the shape, the geometry of the whole thing?
It's both. But the geometry is what defines the danger. If a stricture is tight, so well under 10 millimeters, or if it's long, or, and this is the big one, if it's angulated.
Angulated, meaning it's not a straight shot.
Right. It's crooked. Then you're in the complex category. And this method is it's off the table. Instantly.
Okay, and this is the aha moment for me, the why. What happens if you try this on a complex stricture? What is that immediate life-threatening danger?
Perforation, a rupture of the esophageal wall. It's catastrophic.
Because?
The whole point of a guide wire is to act as a rail, right? It keeps the dilator centered. Without that guide, if you push the flexible Bougie against a tight or angled blockage...
It doesn't go through.
It doesn't go through. It just buckles. It curls up on itself right above the stricture.
And that curl acts like a lever against the wall.
A powerful, uncontrolled lever. And it applies this huge asymmetrical force to the side of the esophageal wall, which is incredibly thin. It doesn't dilate. It tears. And that's a surgical emergency. That's a safety line you just cannot cross.
Okay, safety established. So, assuming we're in the safe zone, a simple stricture, let's talk about the tools. There's more than one type of Bougie for this, right?
That's right. When you're going without a guide wire, you're usually choosing between 2 main types, and it's all about the tip.
The tip, okay.
You've got your Maloney dilators. These are probably the most common, and they have a distinct taper tip. It's designed to gently, find and transition into the stricture.
And what's the other option?
The alternative would be the Hurst dilators, and their main feature is a blunt tip.
So one is tapered, one is blunt.
Right. The Maloney's taper gives you I guess you could say, a gentler entry, which a lot of people prefer for these simple strictures, but both follow that same French sizing scale.
So the endoscopist picks their tool, they figure out their starting size, maybe they want to start in the low 50s French. The prep in the clinic must be pretty buttoned up. What's the assistant doing?
Oh, the assistant's role is critical. The prep is all about minimizing friction and maximizing control. So the assistant needs to grab at least 3 or 4 sequential sizes. If you're starting at 50, you need 52, 54, 56 ready to go.
Makes sense.
And of course, they need lubricant and gauze.
Let's zoom in on the lubricant because the source is super specific about this. It's not just lube it up. It's about where the lubricant goes.
And where it doesn't? This is a fantastic detail. You only lubricate the tip of the dilator, the part that's actually going into the patient. The explicit instruction is to keep lubricant off the endoscopist's glove.
Why is that so important?
Because if the glove gets slippery, the operator loses all that fine motor control. They can't feel the resistance. A dry, firm grip is what allows them to apply that gentle, measured pressure and know exactly when they've met the stricture.
Loss of grip is loss of safety. That makes total sense. Okay, let's get to the insertion itself. This sounds like a real team effort. Walk me through it.
It is. The endoscopist is holding the dilator, but the assistant's job starts immediately. They have to gently but firmly extend the patient's neck.
That's a non-negotiable step.
Absolutely non-negotiable. It's purely mechanical.
And why? What does extending the neck actually do?
It straightens the path. The anatomy isn't a straight line from your mouth down. To get past the back of the throat, the hypopharynx, the bougie, has to navigate what's basically an obtuse right angle.
Ah, I can picture that.
Extending the neck is the physical trick that turns that sharp corner into more of a gentle slope. It makes the whole passage straighter.
So the path is clear. The endoscopist has a firm grip. What happens when the bougie tip actually hits the stricture?
They feel it. It's a tactile procedure. They feel that resistance. And at that point, they apply very gentle, very controlled pressure.
Yeah.
It's not a shove. It's a slow, persistent force until the tip passes through.
And then it's done.
Almost. Once it's through, they might do a little in and out movement just to make sure the passage is widened, and then they withdraw it.
And the assistant has to be on the ball.
Instantly. Ready to take the used dilator, clear it away, and hand over the next size up if they're doing a sequence. The whole thing is this very smooth, synchronized dance.
Okay, so that whole process sounds like the peak of medical control. Two professionals, specialized equipment. Which makes the next part even more surprising. You're saying some patients do this at home. Self-dilation.
Yeah, it's pretty amazing. And what's fascinating is just the level of patient motivation it requires. The procedure goes from this highly skilled two-person clinical intervention to a solo maintenance routine.
The criteria for who gets to do this must be incredibly strict.
Oh, incredibly. They echo all the safety rules we just talked about. First, it's only for people with a history of simple strictures, never for complicated ones. Ever.
Okay.
Second, the patient has to be really motivated and have good manual dexterity. And third, this is the most important part, they have to be trained, supervised, and actually observed doing the whole thing correctly in the hospital before they're ever allowed to take one home.
It's like a certification process.
It basically is.
So how does it change when they're on their own? They don't have an assistant to extend their neck.
The core principles are identical. But now all that responsibility for getting the mechanics right falls on them. They sit or stand, they lubricate the tip, and they have to consciously extend their own neck head back to straighten that path.
Same procedure, different setting.
Exactly. They push gently until they feel the stricture, apply that same controlled pressure, maybe do the little in and out motion, and then take it out.
And I'm guessing the goal at home isn't to keep stretching it wider and wider.
No, not at all. They're typically given just a single dilator size, the final size they reached in the hospital. The goal is just maintenance.
To keep it open.
Right. Taking it maybe once or twice a week just to keep that passage open and prevent it from narrowing again. It saves them from constant hospital visits.
So when you put this all together, what does it mean for us, for the learner? Guide wireless bougie dilation is this. It's a perfect example of a procedure that's super effective, but only in a very, very narrow window.
It really is. Its success comes down to total mechanical precision. The right sizing on the French scale, the perfect non-slip grip, and above all, sticking to that simple stricture rule.
And for anyone trying to master a complex skill, what's the takeaway?
I think it's about understanding the limits of your tools. The real knowledge here isn't just how to do the procedure, it's internalizing that boundary, knowing that taking one step outside that boundary, trying this on a complex stricture, risks that catastrophic rupture.
It's the difference between knowing how to use a tool and knowing when and when not to use it.
Exactly. That's what defines responsible practice.
You know, it leaves me with one final thought, especially thinking about that self-dilation part. We spent all this time detailing the incredible choreography in the hospital. The dry glove, the assistant extending the neck, the doctor's tactile feedback. The source mentions the patients get educational videos. And it just makes you wonder, how well can a motivated patient, alone at home, truly replicate a procedure that is so mechanically precise just based on video. When the stakes are that high,
Yeah.
that shift in responsibility, from a specialized team to one person in their bathroom. It's a pretty fascinating and crucial thing to think about.